So hey everyone, in this video lecture we will be discussing about rheumatic heart disease and what is rheumatic fever. We will be discussing about the pathology, what happens in this disease, and in other video we will be discussing about the microbiological aspect. Like as you can see here, group A streptococcus he has mentioned. So this organism is causing rheumatic fever or rheumatic heart disease. So we will be discussing more detail about this particular organism in microbiology aspect in microbiology video. So here we begin. Rheumatic fever and rheumatic heart disease. So what is rheumatic fever? Rheumatic fever is an acute immunologically mediated multisystematic disease. So what mediated? Immunological. That means our immune cells are playing roles here, and it is a multi-system inflammatory disease. That means it can go to any system and cause disease. It can be cardiovascular system, it can be your joint or neurological system. Okay, so classically occurring a few weeks after group A streptococcal pharyngitis. So usually when it is happening after a particular period, like after a week after streptococcal infection. So initially what happens is, initially there is pharyngitis. Why? Because most commonly either it is bacteria or fungus or any organism that enters through the nose and mouth, most common path. Okay, so the maximum number of cases also shows first pharyngitis, because somehow it enters through the either nose or mouth through food or water or air, anyway. So initially it causes pharyngitis, and if this pharyngitis is not treated properly, okay, if the person is not being treated group A streptococcus, okay, if the antibiotics are not against this particular organism, then he will cause infection. This organism will cause infection. And if there is repeated infection, okay, recurrent infection of group A streptococcus, if he is not being treated properly, then what happens is, slowly this pharyngitis will lead to something called as rheumatic fever, that will lead to something called as rheumatic heart disease. Okay, so if it involves heart, then it is rheumatic heart disease. Okay, so it is a multisystematic disease. How? What mediated? Immunologically mediated. How it is happening? Because the group A streptococcus, so here the main villain is group A streptococcus, and how it happens we will see in this lecture. So rheumatic fever can follow streptococcal infection at other sites, such as it can occur on the skin. Active rheumatic, okay, they have given only one example. It can occur in skin, it can occur in joints, in the neurons also, okay, in brain. So acute rheumatic carditis is a common manifestation of active rheumatic fever and may progress over time to chronic rheumatic heart disease. So yeah, as I said, if the person is not treated properly, if the antibiotics are not against this particular organism, so he won't die. And if he is not dead, then there will be recurrent infection of this same particular organism. There will be recurrent damage to the heart or any other tissue. Okay, so there will be more immunological activation. Okay, so we will discuss how that immune activation happens and what is molecular mimicry. So rheumatic heart disease is characterized principally by deforming fibrotic valvular disease. So it's here he is damaging the heart, especially the valves. Okay, this picture has been taken directly from Netters. So particularly involving the mitral. Among the valves also, their favorite spot is mitral valve, so they like to go and chill there. Actually not them, the immune antibodies. Okay, so indeed rheumatic heart disease is virtually the only cause of mitral stenosis. The incidence and mortality rate of rheumatic fever and rheumatic heart disease have declined remarkably in many parts of the world over the past century as a result of improved sanitation and rapid diagnosis and treatment streptococcal pharyngitis. So yeah, as there is advancement in the medical science, and we know now what we have to do, how to prevent and everything, okay, PSM, community medicine. So as a result of improved sanitation and rapid diagnosis, so the number of cases has declined significantly. So make sure you maintain the hygiene and everything, okay. And if you're feeling sick or anything, any kind of throat issues or inflammation in the your neck region, you need to go to doctor and get diagnosed, okay, or else you might get this rheumatic fever or rheumatic heart disease because of ignorance. So nevertheless, in low income countries and in many low income countries and many crowded, economically depressed urban areas, rheumatic heart disease remains an important public health problem. So not just India, in some countries of Africa and everywhere, okay. So yeah, did we understand the introduction of this topic? So just quick review. What is rheumatic fever? Immunologically multisystematic inflammatory disease. What is the organism causing it? Group A, Streptococcus. So initially it begins with pharyngitis. If it is not treated, then it might lead to some systemic inflammatory disease where the immune antibodies are going and damaging the parts of the body. It may be heart, it may be joint, it may be kidney, it may be neurons and whatever. So especially if it goes into the heart, the mitral valve gets involved, okay. So there will be deformation or fibrosis in the mitral valve, which might cause a stenosis. So if it causes stenosis, then the blood dynamic flow will be hampered. So blood won't be properly going into chambers. So that might lead to again something else. So essentially it is causing carditis. So as we know, a heart has the pericardium, the endocardium, and myocardium, everything. So altogether it causes inflammation. So yeah, we understood something. Next we'll go here. So pathogenesis. Now this is the important, like the concept is here ki how it is happening, how after group A streptococcus infection, how is this rheumatic fever happening. So acute rheumatic fever results from the host immune response to a group A streptococcal antigen that cross react with host protein. So what he's trying to say is group A streptococcus, that is a gram positive organism. We know that is, yeah, gram positive means purple color. So in them, in the cell wall of the group A streptococcus, they have something called as M protein, okay. From the Lansfield classification and Griffith's classification, if you know something about it, or in the microbiology lecture anyways we will discuss, but generally you should remember ki there is something called as M protein, where in the group A streptococcus, in their peptidoglycan layer in the cell wall, essentially in the cell wall they have M protein. Now this M protein is present where in the bacteria. So our body, if anything is coming inside in our body will produce antibodies against that foreign antigen, okay. So in this case it is producing antigen against whom? Antigen against the M protein. But the interesting point here is this M antigen ka jo structure, the structure of the M antigen is kind of similar to certain tissues in our body, and that those tissues are, one is heart, okay, one is heart, then some joints, also some part of the kidney, in the basement membrane, okay, even in the neurons. So this M protein is somehow, I don't know how, but nature is so messed up. The bacteria ka M protein and the body's certain tissues have this similar structure or similar something. So our immune cells, they get confused. So once they produce these antibodies against the M proteins, and let's suppose the bacteria are cleared and everything is gone, so bacteria is gone now, but still the antibodies will be remaining in the body. These antibodies, they will scan throughout the body, okay, for this M protein, because it's their job. So whenever they find such similar structure in the body, maybe in the heart, maybe in the kidney, maybe in the joints, maybe in the neurons, so they go and attack them. They form clumps, they activate complement system, and there is inflammation, okay. So essentially I have explained you the mechanism. We'll just read through it. Acute rheumatic fever is the result of host immune response. So acute rheumatic fever is Now this rheumatic fever is because of whom? Is it because of the bacteria? No, it is because of our own immune system. Bacteria ka part is done. He was causing this thing, what, pharyngitis. So that part is done. Now this is our immune system who is troubling us. Now after the bacteria is gone, now immune system is getting confused. He is messing up with our tissues and he is causing the inflammation. So acute rheumatic fever results from the host immune response to a group streptococcus antigen that cross react with host proteins. So host is we are the host, the proteins are within us, so they cross react with our proteins. The characteristic 2 to 3 weeks delay in the symptoms onset often after infection is explained by the time needed to generate an immune response, in particular antibodies and CD4 cells directed against streptococcal
Yum protein.
can also in some cases recognize cardiac self antigen. So this similar protein is present in the heart, so they recognize them as a foreign body or something. So antibody binding can activate complement, and as I have mentioned, key complement means inflammation and everything will happen there, as well as recruit FC receptor binding bearing cells. So this FC and everything, if you are getting confused, it is nothing but that those antibodies, they have certain regions. Okay, so they have like Y-shaped kind of thing. There we have FC receptors and all. That in another lecture we will be discussing. We will discuss about immunological part. You just have to remember there is streptococcal M protein which is being cross reacted by our own immune cells, and that's how this rheumatic fever will begin. Cytokine production, see all the cytokines and all this is damaging, essentially it is damaging the heart, so leads to macrophages activation. Example within the heart. Now this, what is Ashkoff bodies? Ashkoff bodies, see, you can see the picture here, you can see the picture here also. What is Ashkoff body? It is around 1 to 2 mm lymphocytes, macrophages, Anitschkow cells and giant cells, Ashkoff cells. All these are present. Where it is present? As I have mentioned, the favorite spot of these antibodies is in the mitral valve. So these antibodies will go and attach somewhere in the mitral valve, because they think some portion or any part of that mitral valve may be similar to that M antigen. So the antibodies goes and attack the mitral valve. after active After attaching themselves with them, there is activation of the complement system and inflammation. So once the inflammation has started, so neutrophils will come, macrophages will come, so all this immune cells, T cells and everything will come there. So once they come there, they will, unnecessarily they will just start attacking our mitral valve, and they will destroy the cells of the mitral valve. They will themselves also die there. So it forms a clumps of dead bodies and necrotic part. Okay, so that clumps are nothing but they are calling it as Ashkoff body. Okay, so in that we have lymphocytes, macrophage, and its couch cells and giant cells. Okay, so giant cells is essentially formed by the maybe 2-3 macrophages. They came together and fused together forming giant cells. There is no myocytes, perivascular Anitschkow cells. These Anitschkow cells are also called as caterpillar cells because they look like caterpillars. See, you can see here. Are you able to see here? See, this looks like caterpillar, right? See here in this diagram. So Ashkoff body, cardiac. So this is all cardiac myofibers. Take a normal cardiac fibers. Then these are the macrophages. Then abundant cytoplasm and caterpillar-like longitudinal section or owl eye-like appearance. Owl eye. Where is owl eye? Guys, are you able to see owl eye kind of appearance? This one. Owl eye usually is seen in the Hodgkin's lymphoma and everything. Okay, that is different topic. Okay, maybe if he's saying, okay, then Anitschkow cells fibrinoid necrosis. So why is there fibrinoid necrosis? Because maybe there is deposition of fibrin proteins and all. Okay, so this because of that fibrinoid necrosis. Then we have multinucleated fused giant cells, okay, and then lymphocytes. So yeah, we have understood ki they so the mitral valve, there will be inflammation there, all the cells are coming there, they are making clumps and groups, and these cells and these clumps and groups are nothing but the ascope body. In ascope body we can see caterpillar like longitudinal section or owl-eye like cross section, then we have multinucleated giant cells, there will be few normal cardiac cells surrounding the whole thing. Okay, there is fibrinoid necrosis and everything. So we understood the ascope body also. So damage to heart tissue may thus be caused by a combination of antibody and T cell mediated reactions. In keeping with an immunologic basis of rheumatic heart disease, streptococci are completely absent from the lesion because only a small minority of infected patients develop rheumatic fever, estimated at 3%. A genetic susceptibility is likely to influence the development of the cross-reactivity immune. Okay, so and general thing is talking now ki, okay, these patients might get affected with all this. So yeah, and the whole thing that I have explained, okay, the immunological basis of this disease, this thing is called as molecular mimicry. So yeah, the word is self-explanatory. What is molecular mimicry? Because the body parts, the tissue of our body is mimicking the M protein of that bacteria. Which bacteria? Group A, streptococcus. Okay, the development of the cross-reactivity immune response, the chronic fibrotic lesions are the predictable consequences of the healing and scarring associated with the resolution of the acute inflammation. So there will be formation of the chronic fibrotic lesions and everything. Okay, next, as you can see, what is this? These are all cusps or the leaflets of the valve. Okay, so as you can see, different kind of patches or clumps have been formed in these valves. So here, as you can see, this is the rheumatic heart disease scenario. This is infective endocarditis. This is a separate lecture. This is your non-bacterial thromboembolic carditis, I guess, non-bacterial thrombotic endocarditis. Then here we have Liebman-Sachs endocarditis. Okay, so we'll be discussing about the rheumatic heart disease. What he is telling here. See, comparison of the four major forms of vegetative endocarditis. So all these are vegetations. Okay, so in this maybe there is presence of five what is it, platelets or fibrin, maybe there is presence of bacteria, so which has bacteria is called, maybe that is septic, which is not bacteria, which is that is non-septic. Okay, so rheumatic fever phase of the rheumatic heart disease is marked by small, so in rheumatic fever it is marked by small warty vegetations along the lines of the closure of the valve leaflets. So along the line of the closure, so when the valve is opening and closing, so along the line of the closure, when the valve is closing, so along the line of that closure there is formation of this small warty vegetations of what? Vegetations of those immune complexes that has been deposited there, all those ascope bodies and everything. So can extend onto the chordate tendon. And okay, if we talk about the infective endocarditis, it is characterized by a large irregular mass on the valve cuffs that can extend to the, so in case of infective endocarditis, in this directly bacteria is present there. Okay, so in infective endocarditis, bacteria might enter into the body from maybe skin lesions like impetigo, and whatever the skin lesions is caused by that particular bacteria. Okay, there can be rashes, something called scarlet fever. Okay, then any pus formation and anything, so that can travel to the heart and it can form those kind of vegetations, their colonies and groups, and they live happily in the mitral valve and other valves happily. Okay, so then we have non-bacterial thrombotic endocarditis. In this, because of some kind of coagulation pathology in the body. What is coagulation? Coagulation is when our blood it clumps, it coagulates. Okay, so because of that, some pathology in the coagulation factors or anything, or maybe there is stasis of the blood there or anything. So non-bacterial thrombotic, this is because of the thrombus formation, thrombotic endocarditis, that is why it is called as NBT. So that will be, the scenario will be like this, as you can see here. Then there will be exhibit small bland vegetations usually attached at the line of the closure. One or maybe many or one or may many one or many may be present. Libyan sacs endocarditis LSC has small or medium sized vegetations on either or both sides of the valve. So this is essentially caused by the something called as SLE. What is SLE? Systemic lupus erythematosus. That is also an autoimmune disease. So here also immunological basis. So this is the summary. Rheumatic heart disease, small white vegetations along the line of the closure due to autoimmune damage from the rheumatic fever. Infected endocarditis, large irregular vegetations caused by the active infection often leading to valve destruction. So then we have NBTE sterile. This is sterile. Why? There is no bacteria here. There is only thrombus formation. There's something wrong with the blood coagulation system. So that is called as hypercoagulable states, often located on the line of the closure. LSA is Libyan sacs endocarditis caused by the SLE. Okay, next. So these are the real pictures of the heart taken from the Robbins. So morphology, we'll discuss about the morphology. Okay, how it looks. How it looks when we cut open the heart. Okay, a patient has a patient has rheumatic heart disease or rheumatic fever. So once it progresses to heart disease, how does it look grossly? How does it look in? So key pathological features are this: during acute rheumatic fever, focal inflammatory lesions are found in various tissue. Focal inflammatory lesions are found in the various tissue. Why focal inflammatory? Because antibodies are going there. There is complement activation, inflammation. So macrophages, lymphocytes, neutrophils, everyone will come there and they will clump and they form these focal inflammatory lesions called as Ascope bodies. In the heart it is called as Ascope bodies. As you can see here, I think these are the marks of those. Okay, so are composed of foci of T lymphocytes, occasional plasma cells, and plump activate macrophages called as Anichkov cells. We have discussed all this earlier. These macrophages have abundant cytoplasm and central round to ovate nuclei, occasionally binucleate. Okay, so occasionally binuclear. So if there is two nucleus, then it might be looking like owl eye appearance. Yeah, I understand now. In which the chromatin condenses into a central slender wavy ribbon, hence the designation of the caterpillar cell. So why are these caterpillar cells they are looking like that? Because he is telling ki the chromatin condenses into a central slender wavy ribbon like. See, in the cell the chromatin, the DNA and everything, the genetic material, it is forming condensed and wavy ribbon like structure. So that is looking like caterpillars. Okay. Yeah, so that is there. During acute rheumatic fever, diffuse inflammation and Ascope bodies may be found in any of the three layers of the heart. So totally, so heart has three layers: pericarditis, myocarditis, endocarditis. Anywhere it can be found. Altogether it is called as pancarditis. What is pan means? Total, the whole part of the heart. Inflammation of the endocardium and the left side valves typically results in the fibrinoid necrosis. So inflammation of the endocardium. The endocardium lining will be similar to that of the intima of the blood vessels. So in the blood vessel also we have different parts: tunica intima, tunica media, tunica adventitia. So the tunica intima is continuous with the heart interior part, right? The endocarditis, the endocardium. Inflammation of the endocardium and the left sided valves. Endocardium, okay, inside the heart, and the left sided valve typically results in the fibrinoid necrosis within the cusp or tendinous. What? Tendinous cords. Overlying these necrotic foci and along the lines of the closure are small 1 to 2 mm vegetations called as verrucae. These are called as verrucae. Thus, rheumatic heart disease is one of the form of vegetative valve disease. This is one of the form of vegetative valve disease, each of which exhibits their own characteristic morphologic features. Figure 1, this one, subendocardial lesions perhaps exacerbated by regurgitant jets can induce irregular thickening called as McCallum plaques, usually in the left atrium. So essentially they are causing damage to the valve of the heart. So if there is damage to the valve of the heart, there is continuous the heart is pumping continuously, there is flow of the blood continuously in the heart, so it should be stable, right? The flow of the blood should be stable. If the flow of the blood is unstable, then there will be other kind of pathologies will develop from that. And why the blood flow is unstable? Because of the damaged valve. The valve is getting damaged here, so either it is not able to close proper or open proper. That all might cause this regurgitant jets, can induce irregular thickening of that part of the valve, or maybe the adjacent part of the mitral valve or the endocardium. Okay, these are called as McCallum plaques, usually in the left atrium, so where there is mitral stenosis, around that region anyway. The cardinal anatomic changes of the mitral valve is in chronic rheumatic heart disease are leaflet thickening, commissural fusion, and shortening and thickening and fusion of the tendinous cord. So what are the cardinal anatomic changes? So if a person has rheumatic heart disease, what changes you will see? You will definitely see, kind of. So you can see in rheumatic heart disease are the leaflet thickening. So these leaflets, okay, there will be thickening of these leaflets, commissural fusion. I'll just show you that picture here and then zoom in. So this is the mitral valve. Okay, so these are the cusps. See, these are the cusp. Here it is given mural leaflet, commissural leaflet. So these are all the commissural. So here at this point, at these points, there will be thickening and fusion of the tendinous cords. Okay, see in the figure 12.22. Okay, which one is the D1 here? Here, as you can see. Okay. At this part there will be thickening and all right, thickening of the and fusion of the tendinous cords. The mitral valve is virtually always involved in the chronic rheumatic heart disease. That is virtually involved. I mean, that means maximum number of the cases have been seen this mitral valve is getting involved. It is affected in isolation in roughly 2/3 of the cases, and along with the aortic valve in another 25%. General data. In rheumatic mitral stenosis, calcification and fibrous bridging across the valvular commissure create fish mouth appearance. This one, it looks like similar, so that is fish mouth appearance. All right, see, okay, so it looks like fish mouth appearance. Pointer. Next, with tight mitral stenosis, the left atrium progressively dilates and may harbor mural thrombi that can embolize. So with tight mitral stenosis, so if there is mitral stenosis there, this mitral stenosis means what? It is not properly opening. Okay, so there is narrowing of the opening of the valve. So if it is not properly opening, means there will be stasis of the blood. Okay, tight will happen, there will be more blood stasis in the left atrium, so left atrium will dilate. So there is the dilatation of the left atrium may harbor mural thrombi. And if there is stasis anywhere in the body, if there is stasis, and if the person is not healthy enough, the coagulation pathway, the coagulation system is not healthy enough, then if there is stasis, then there will be formation of the thrombus because of the deposition of the fibrin and every other that components required in the coagulation. And because of this, there will be formation of the thrombi which can embolize. So thrombus emboli, what is that? So there is formation of the thrombi, clumps of platelets and fibrin deposits that will be formed there, and it will pass from that opening somehow, then it will travel into the blood vessels, anywhere it can go. So that is called as embolism, like in deep venous thrombosis. Okay, the thrombus is formed in the DVT, in the your leg region, and from there it will break down some part of that thrombus. It will embolize, okay, to your pulmonary vessels. Okay, so that is there. So fish mouth stenosis with tight mitral stenosis, the left atrium progresses, all these things we have read. Ventricle is largely unaffected by isolated pure mitral stenosis. Microscopically, valves show organization of the acute inflammation. See, this is the microscopic feature, picture. We'll zoom in. So what he is trying to say, so these are normal myocardial cells. These are all normal myocardial cells. Can we see any caterpillar formation kind of? Are you able to say? I think this is one here, one is here, I guess. Okay, it looks like caterpillar. Architecture and everything. Ascope bodies are rarely seen in surgical specimens or autopsy tissue from the patient's chronic rheumatic heart disease because of the long interval between the initial insult and the development of the chronic deformity. So Ascope body is rarely seen in surgical specimens and autopsy. You just read that part, okay? We'll move on. I don't want this video to go too long. Then it will be difficult for me to edit. Clinical features, rheumatic fever. So what are the clinical features? If you have got rheumatic fever, what will you experience? Rheumatic fever is characterized by the constellation of major manifestations. So we have 1, 2, 3, 4, 5 things. Okay, we need to remember this because there is something called as Jones criteria. Okay, Jones criteria, and in infective carditis we have Duke's criteria. So in Jones criteria you have to remember all this. What are the important things? Okay, so in microbiology we'll discuss this again, but let's see. So we have migratory polyarthritis. So why is there polyarthritis? What is arthritis? Joint inflammation. Okay, so anyway, maybe knee joint or elbow joint, anywhere in the body, in the joints. So there, why there is pain, swelling? Because there is deposition of those antibodies. I told you, M protein is similar to some tissue of our body: heart, joint, neurons, kidney. Okay, so here also a migratory polyarthritis, maybe today it is paining me here, next day it is paining in my knee, next day it is paining somewhere else. So migratory polyarthritis. Then we have pancarditis. What is pancarditis? So heart has three layers: endocardium, myocardium, epicardium, or ectocardium. What is that? Whatever. So the all the parts of the heart is getting myocarditis, pericarditis, endocarditis. So totally it is pancarditis. Valve disease and all. Subcutaneous nodules. Okay, so there will be formation of some subcutaneous nodules on the skin. Then we have erythema marginatum, an irregular circinate skin rash. This is kind of a skin rash. Erythema marginatum. Then we have syndrome scoria. What is syndrome scoria? Syndrome scoria is nothing but the dance. So because of the neurological disorder with involuntary rapid movement, so they will start involuntary rapid movements. Okay, that is called as syndrome scoria. Sydenham scoria. Then the diagnosis is established in accordance with the revised Jones criteria. Evidence of a preceding group A streptococcal infection. So what is the evidence that this might be rheumatic heart disease or rheumatic fever? There should be infection of group A streptococcus, and the presence of two major manifestations, or one major and two major manifestations. No, okay. So if you have to diagnose this is a rheumatic fever, so first you need to be assured ki okay, this has been caused by the group A streptococcus, and any of those criteria should be there: migratory polyarthritis, on pancarditis, or subcutaneous nodules, erythema marginatum, syndrome scoria. So what are this? We have migratory polyarthritis, we have pancarditis, subcutaneous nodules, then we have erythema marginatum, the skin rashes, and then we have the syndrome scoria. Elevated blood levels of acute phase reactants, fever, arthralgia, all these things are non-specific. Then acute rheumatic fever typically appears 10 days to 6 weeks after a group A streptococcus infection in about 3% of the patient's children between 5 to 15. This is the most common age when it happens. So children between 5 to 15 years of the age. Okay, so attacks can occur in the middle to later life, although pharyngeal culture for streptococcus are negative by the time the illness begins, antibodies to one or more streptococcal enzymes such as streptolysin O and DNase B can be detected in the sera of patients with rheumatic fever. So the predominant clinical manifestations are carditis, arthritis, migratory polyarthritis, and everything. So in the lab reports, in the lab diagnosis, the microbiological department, what will they give report? They will give report something called as ASLO, anti-streptolysin O antigen or antibody. Okay, so that will be detected. And where is this coming from? This is coming from the bacteria. The streptococcus bacteria has this streptolysin O, then they have DNase. Okay, so all these are their virulence factors, toxins. So this streptolysin O has also different two types. One is your heat labile or heat stable, then oxygen labile or oxygen stable. So in microbiology we'll discuss that. Streptococcus. So yeah, initially the antibodies to one or more. So if we find the antibodies of streptolysin O or we find the antibodies against the GNSB, this can be detected in the patients of the sera. The predominant clinical manifestations are carditis. Initially it was just pharyngitis. Then it was systemic inflammation, that is rheumatic fever. Then if it is still not properly treated, then it will cause rheumatic heart disease, slowly damaging the valve, slowly damaging your joint, synovial joints and everything. So if you are not properly treated, then this will lead to this condition, heart disease. Consequences of valve pathology may contribute to progression of the valve pathology in a positive feedback loop. So once if the valve is damaged, so because the damaged valve, this anyways the heart has to beat, so he will beat, he will try to pump the blood through the body, throughout the body. So blood has to flow properly from the atrium to the ventricle, but the valve is damaged, but still heart is beating, it is not giving time to repair or anything. So once there is damage, then because of the continuous flow, continuous pumping, there will be again more damage, more damage, more damage. So that is kind of a positive feedback loop. Clinical manifestation of the rheumatic heart disease appears here or even after the decades after the initial episode of the rheumatic fever, and depends on which the valves are involved. It, in addition to cardiac murmurs, cardiac hypertrophy and dilatation, and heart failure, individuals with chronic rheumatic heart disease may suffer from arrhythmias, particularly atrial fibrillation in the settings of mitral stenosis. So, in addition to cardiac murmurs, cardiac hypertrophy and dilatation, and heart failure. Uh, so if a person who initially if he has any kind of cardiac problems and then again he has rheumatic heart disease, that means he will be damaged more, he will suffer more, he might suffer from arrhythmias and all. Okay, so thromboembolic complications and infective endocarditis will also be part of the complication. We know what is thromboembolic complication. So there is formation of the thrombus because the clumping of the platelets and fibrin and everything that is getting detached from its parent thrombus. Embolizing means going somewhere in the body and blocking something, maybe in the pulmonary veins, maybe small tiny capillaries somewhere in the body, anywhere it is going and it is occluding the blood flow. And infective endocarditis, if there is direct bacteria is going inside the valve of the heart, they are causing inflammation directly there. Okay, so that is infective endocarditis. Yeah, so we are done with this. So rheumatic fever, this is one of the important topic for the university exam. Okay, and one of my brother, he was diagnosed with rheumatic fever. Okay, my mama ka ladka. So when he was a kid, he was diagnosed with rheumatic fever. So once when I went to his home, and there he was there, they they get injections of penicillin. Okay, so at that point I was not knowing what is rheumatic fever, what is penicillin and everything. I was like what class 7th or 8th, I don't know, around that, but at around that time. So he had this rheumatic fever. So when I was at his home, so every month around I think 28 days or 30 days they have to take this penicillin injection in their gluteus maximus. Okay, in their back. So it was the day when he has to get that injection penicillin, and it is very painful. Okay, so the whole day he was so stressed, he was so afraid of that injection. Okay, I was there with him and we both were small. Okay, so we were kids at that time. And so from that I remember ki, okay, rheumatic fever is something, then penicillin is something. And rheumatic fever people, they get penicillin every month, one dose of penicillin. Okay, so it is given in the gluteus maximus. So that day he was so scared. So when the doctor comes to the home, his heart was racing. He was totally scared, and he was like, "Brother, I want to shit. I want to go to toilet. I can't take this." So that was memory, and that's how I remember rheumatic fever. So yeah, that was the topic, and next we will be discussing about the microbiological aspect of this streptococcus, group A streptococcus. So that's all.